So all recordings when we do Zooms will be uploaded to YouTube, excuse me, and then I'll paste or post the link in the resource folder section. It takes a while to process and then upload to YouTube, so it won't be available right after the lecture. So just so you know. We have a couple more joining. Okay, so a little bit about me, because it's been a while since you guys started. I worked at St. Anthony's Hospital in Lakewood, which is a level 1 trauma. So I specialize in adult critical care and emergency care is my area of expertise. I've been teaching at Pima for about 2 years now. I just started as the clinical director in April. So I'm on week 3. So be patient with me. I have a lot of new trainings and learning how to do that job on top of teaching you guys. And then I have another class as well. So I will work as hard as I can to get everything graded in a timely manner. Always feel free to reach out with questions, even if it's after office hours. I can't guarantee I can get back to you right away, but at least you'll have the question written down so that you don't forget it. So always feel free to do that. The last class we have in microbiology, we're going to go over Peabody, so we can start getting you set up with that. And you'll be able to start putting on your professional hours. And then we will also go over a clinical class that I'm creating for you, so you can start uploading the paperwork that I need to send to hospitals. So we're not struggling last minute. Okay, so let's start with bacteria. We're going to start with gram-positive. Okay, can everyone see it? Okay, I lost my... Hold on just a second. Try this again. Okay, there we go. So gram-positive bacteria, things to remember. So remember, all bacteria are prokaryotes. So prokaryotes translates to pre-nucleus. So remember, bacteria don't have a defined nucleus. They have very simple DNA that is in that circular form, but it's not contained within a nucleus. The body fights them with leukocytes, which are white blood cells. And then hospitals fight them with antibiotics and also prevention. So you are going to hear common themes within this class of preventing infections to begin with. So as healthcare workers, we want to be very cautious about infecting our patients. So that would be for RTs, if we are drawing blood from an arterial line, looking at that site. So any indwelling catheters, so arterial lines, IVs, urinary catheters, we are more likely to cause infection with indwelling catheters, endotracheal tubes. So we want to make sure that we are looking at them for signs of infection. So redness, swelling, pain, pus, any of those are going to be a sign of infection. So just be mindful of that. So Dr. Hans Christian Gram created a staining technique called the Gram stain. And the Gram stain is the most important staining procedure in the lab at the hospital, because that's going to tell us first what type of bacteria we are dealing with. So the patient's specific bacteria, whether it be in sputum or a blood sample, it could be in urine or feces. So that's going to tell us what we're fighting, but it's also going to tell us what antibiotics it's resistant to or susceptible to. So what's going to be the best antibiotic to treat it. So a lot of physicians, once a patient shows signs of an infection, whether it's that redness, swelling, pain, if they have a cough, a fever, chills. We'll start them on broad spectrum antibiotics until we get the results of what the bacteria is and what it's susceptible to. So you'll hear the term broad spectrum antibiotics, and that's what it means. It's like an umbrella. It covers lots of different bacteria infections that it can start fighting until we get the specific bacteria. So with this gram stain, there are two general categories, one being gram positive and one being gram negative. And how the stain works is if the bacteria is stained and it turns blue or purple, it's going to be gram positive. If it's red or pink, it's going to be considered gram negative. So know, excuse me, know that what colors the bacteria will turn if they're gram positive or gram negative. So here are some examples of what it would look like under the microscope after that gram stain. So positive, you can see it's purple, P for purple for positive. Gram negative bacteria tend to be harder to treat with antibiotics, and they're more invasive. They can cause a lot more side effects, and we'll go over that in the next PowerPoint. How I like to think of it is gram negative tend to be more nasty bacteria. They cause more damage. So bacteria can be identified by color of staining, by morphology, which is the grouping of the shape of bacteria, which we will go into in the next few slides, and then by the cluster styles. So you can see here in the purple, they're in long chains, whereas in this picture, they're more in groups or pairs. So color, shape, and then how they're clustered together.
Could that be like for the positive? Could that be like, are they magnified about the same too?
The positive is probably magnified a little bit more than the negative. Good question.
Okay.
Another technique that we use for staining is acid-fast staining, and we'll get into this more on Friday when we talk about our mycobacterium. But I wanted to kind of put the staining techniques together. So acid-fast staining is going to be used to determine specific types of bacteria that are mycobacterium. So the most common that we've heard of is tuberculosis, is a mycobacterium. So they are going to stain different because mycobacterium cell wall is wax-like. So that means that their cell wall has higher amounts of lipids in the cell wall, so it's harder to penetrate with the gram stain. So the acid-fast stain is going to use heat to drive in a red stain into the cells. And then they will add a decolorizing agent to it to try and take out that red stain. If the red stain stays within the cells, they know that it's a mycobacterium because that heat will kind of open up a little bit for that stain to go in. But when they use a decolorizing agent, that cell wall, the fats have cooled down, so it's not going to release that stain. So if it stays red or pink, then it is a mycobacterium. And mycobacterium are highly resistant to disinfectants because they have that thicker cell wall. And if it's waxy, like any type of liquid is going to roll off. So it's like if your windshield gets covered in rain and it just kind of rolls off, it's like that principle. And if I'm ever going too fast, just let me know.
Stacy, what are they highly resistant? I didn't catch the last part.
To disinfectants. And they can live in drier conditions than typical bacteria because that cell wall preserves them. Okay, so our body will naturally protect us from bacterial infections. So we have chemical or physiological barriers, which would be body temperature. So when we get some sort of infection, if we get sick, if we get a respiratory bacterial infection, our body will spike a fever. So that's the body's natural reaction to try and kill the bacteria by heating up by our body's pH. So our body naturally will go out of homeostasis to try and get rid of this pathogen. And then our body's secretions. So nasal secretions, saliva. That's why we have an acidic atmosphere in the stomach, not just to digest food and start to break it down, but also to kill any pathogens that we may ingest. And then in our tears, our saliva and blood plasma, we have lysosomes, which are little enzymes that are going to try and get rid of that pathogen. And then our biggest mechanical and most important barrier is going to be our skin. It protects us from these pathogens crossing that and getting into our blood and into our tissues. And then mucous membranes. So our mouth, our nose, that's why we have earwax, because if pathogens get in there, the mucous membranes are hopefully going to stop them and prevent them from going further into the body. So further classification of bacteria. So we can have them grouped by the shape of the organism, and we're going to go over each of these individually. So we have cocci, bacilli, and spirilla. So this would be morphology here, grouped by shape, morphology. And then we can further break them down and also group them on how they're arranged. So strepto, staphylo, and diplo. And we're going to go over each of these. So cocci are spheres, and some examples would be streptococcus, staphylococcus, and diplococcus. So you can see these are circles. And would this be gram-positive or gram-negative? What color are they? Positive. Yep, they're purple. And then we have rods, which are bacilli. Most of them are opportunistic pathogens. So like E. coli we have naturally in our intestines. But given the opportunity and the right environment, they will infect us and cause an infection. So bacilli can be short or long, thick or thin. They could have pointed ends or curved ends. So they might differ in shape, but they're going to be more of like a cylinder. And then you have spirilla. In singular terms, it's spirillum, and they're more of a spiral. They remind me of those spiral noodles that my daughter likes to eat. And then we can group them by arrangement. So first we look at the shape, and then we look at how they are grouped together. So strepto, so this would be an example of a streptococcus, because they're circles, would be a chain, a twisted chain. So know what each shape is, the term, and how they're grouped. And I did post a Quizlet in today's content that has all those definitions as well. And then you have Staphylo, which is a group of bacteria or a cluster. So this would be Staphylococcus because they're grouped together. There's not a definitive chain or just pairs. And then Diplo would be linked together in pairs. So you can see these little bacteria here. You can see a thin white line in between. So they're like twins. They're conjoined together, but they're pairs. Okay, so let's start talking specifically about gram-positive. So purple or blue stain, they produce exotoxins. And exotoxins are a toxin that is secreted by the bacteria. And it causes damage to those toxins cause damage to the host by destroying our cells. So it's destroying the white blood cells that are trying to fight it, as well as cells that are living in the area of the infection. They can be highly potent and eventually cause sepsis. Who knows what sepsis is?
Isn't it when the gets in your bloodstream, like the infection, so like you become septic?
Yep,
Blood infection.
exactly. It's a blood infection. So sepsis starts with a localized infection, whether it be an infection of an area of tissue or a respiratory infection that goes untreated or isn't treated properly. And then it goes to septicemia, excuse me. My allergies are bothering me today. So it goes to septicemia and eventually goes to the blood. Well, because the blood is circulating throughout the entire body, these toxins are going throughout the entire body and can cause organ failure, and then eventually can lead to septic shock, which we'll learn about in emergency care. And if shock isn't reversed, it will result in death. So getting treatment for our patients right away who have a bacterial infection is crucial. So gram-positive bacteria, what makes positive and negative bacteria different from each other is their cell wall structure. With gram-positive bacteria, they're going to be easier to treat. They do have a thick layer of peptides that create the cell wall. The thicker the cell wall, the more blue or purple will be picked up on the slides. And remember that this one is easier to treat with antibiotics than the gram-positive, or the gram-negative, excuse me.
So just to clarify, was it the positive or the negative cell walls are thicker?
The gram-negative cell walls are going to be thicker.
Okay.
Gram-positive, they are going to vary in thickness, but the thicker that individual cell wall is, the more stain it's going to pick up. That's what I want you to know.
Okay. And they're thicker because of the lipids?
So that's the mycobacterium. So they're thicker
Okay.
because they've got multiple layers in the negatives. So their structure is going to be a little bit different. So talking about sepsis and bacteria infections, we worry about antibiotic resistance because the bacteria are outsmarting us and the old antibiotics. So when a bacteria is introduced to an antibiotic, it starts to mutate. It starts to change its DNA so that those antibiotics no longer affect them or kill them. So currently right now, there are 15 new antibiotics in the pipeline. So a drug pipeline is where you can find research on specific types of drugs. So if you're looking just for antibiotics, you'll find a drug pipeline, and it shows the different stages of clinical studies, which starts with a hypothesis in the lab, and then they study on animals, and then eventually on humans, and then you can see where the development is and if it is FDA approved. So there are 15 new antibiotics in the pipeline, but realistically, probably only 2 or 3 will make it to the marketplace because of whether the side effects are too bad for humans or there's no longer a need for them because they find that there's already resistance during the studies. So it's important that we properly educate our patients about taking antibiotics and finishing their antibiotic, not taking an antibiotic just because they have some sort of cold symptom that may be viral, because the antibiotic or the bacteria that's in their body will be exposed to that antibiotic. And then that bacteria can start mutating. And I will give you, I will let you go back and watch this YouTube video. It's in a laboratory in a hospital, and she explains how they stain for bacteria and find which antibiotic works for each bacteria. So bacteriostatic versus bactericidal. So bacteriostatic is going to mean that it prevents growth or reproduction of a bacteria. So if we give a patient an antibiotic that's bacteriostatic, we're preventing further growth of that bacteria. If we give an antibiotic that's bactericidal, then it's going to kill the bacteria. So I think of homicidal kill. So it'll kill the bacteria. Also, when you start working in the hospital and you see cavi wipes, it'll tell you on the container if it's a bacteriostatic cleaning agent or it's a bactericidal cleaning agent. So this is going to be important when we are cleaning bronchoscopes or cleaning any tool that we use to treat our patient. Because we don't want to take bacteria from a tool that we use with a patient into another patient's room who doesn't have that infection, then we cause them to become sick because we didn't properly clean our equipment. And the same applies to viral static and virucidal, only it's referring to killing a virus or preventing a virus colony from growing further. So penicillin was the first developed antibiotic in 1943. It is not prescribed as often now because bacteria has had so much exposure to penicillin that it has developed resistance. So another kind of scary example would be fluconazole, which was approved in the FDA by 1990. But by the time it finally got approved by the FDA, 2 years before that, there was infections that were already found to be resistant to it in the studies. So antibiotic resistance can happen quickly. Right now, the CDC is worried about Klebsiella pneumonia and its resistance to so many strong antibiotics. So this is just a cool infographic that shows you the importance of making sure it's a bacteria before you are treated with an antibiotic. If they think if a physician thinks it's a virus or is not sure, they're not going to treat it with an antibiotic right away. So here are some gram-positives, and we'll go over each individually. Staphylococcus aureus, Streptococcus pneumonia, diphtheria, Bacillus anthrax, botulism, and tetanus. So Staphylococcus aureus. So staph, remember, it means it's a cluster, and coccus means spheres. So Staph aureus. You might also hear it referred to as Staph aureus. Obviously, it's gram-positive. It is facultative pathogen, which means, how do I want to say it? It means it can live with or without oxygen. So it can be aerobic, meaning that it thrives and it grows and it develops energy with oxygen, or it could be anaerobic, which means that it can thrive and produce its own energy without oxygen present, which is scary. It means you can't suffocate it. It will survive in both oxygen-rich and oxygen-depleted environments. It's opportunistic, so it usually will not cause an infection to a host unless the immune system is already compromised. It may be on a host's skin, but it doesn't cause an infection until there's a broken area of the skin. So it's opportunistic. So generally, it won't hurt somebody, but given the chance to cause a further infection, it will. So a simple term that the public has commonly heard is a staph infection. So that's when the bacteria enters the body. So symptoms include those that we've already talked about: swelling, warmth, redness, pain, sores. It could be somebody has broken skin and has come into contact with staph and it causes an infection. It can happen in a surgical site that's not properly taken care of, both once the patient goes home or in the hospital. Diagnosis requires medical history, physical exams, and then tests. So what they mean by tests is that we'd have blood work done. If it's, for example, a surgical site, they would swab that site and then send it to the lab to see if staph grows. And then treatment, it's easily treated with antibiotics. Easily treated with antibiotics. If it's a rash, sometimes it presents as a rash. Dermatologists may give an antibiotic cream. So this would be a picture of a staph infection of the skin. So within that pus, in that infected area, you have the staph in clusters, in groups, causing that swelling and that redness. And the white blood cells are rushing to that area to try and fight the bacteria, which causes inflammation. Staph is becoming more resistant to antibiotics. So methicillin, which is derived from penicillin, now you have MRSA because that staph is resistant to methicillin. So any of the Cillins are not going to treat MRSA. And then with those antibiotics, we treat with vancomycin or azithromycin. But the bacteria has gotten smart, and now they have developed a resistance to vancomycin or azithromycin, and that's called VRSA. It's a lot less common. When you're in the hospital, you'll likely see MRSA, and you'll hear terms like MRSA of the nares. So what that means is a patient came in our ICU, we would always swab the patient's nares and test them for MRSA as soon as they got admitted to our unit. And then it would come back, it would say, oh, they have MRSA of the nares. So then we would put them on what's called contact precautions. And we'll talk about different precautions and PPE later in this class, but you would always have to wear a gown. You would always have to wear gloves. Make sure you're practicing good hand hygiene, because we don't want to forget to foam in and out, or foam out and go to the next patient's room and then give them MRSA as well.
I was allergic to amoxicillin. When I was a kid, I think they used to always have to give me erythromycin because I had like strep throat and tonsillitis a lot until I had them taken out. Is that amoxicillin's part of penicillin, right?
Yep, all the Cillins.
Yeah, so I couldn't take any of that as a kid or now.
Oh no. So when you guys haven't got to intro to pharm yet. So a lot of, if you see it, the last part of the drug, all the Cillins, amoxicillin, penicillin, methicillin, and there's one more. And just like the mycins, vancomycin, azithromycin, they're all the same family of drugs. So if someone had MRSA, you wouldn't want to give them amoxicillin because all the Cillins are going to be resistant to that to that bacteria. So staph is something that can be found normally in your lungs. It can be part of your normal flora. So my daughter Marilyn has cystic fibrosis, and every time she has clinic, she has to give a sputum sample because they want to see if she's growing anything new or if they've increased in numbers. So she's grown Staph aureus for as long as I can remember, since she was a little kiddo. But they're not worried about it because it's part of her normal flora. Now, if she was starting to show signs and symptoms, she was coughing more, she had increased mucus production, she started developing a fever, and they did a culture and she still had staph, but the numbers increased, then they would treat it. But they don't want to treat something that's not causing symptoms. So now we have Streptococcus pneumoniae, another gram-positive. It's a facultative anaerobe. So it still can live with oxygen, but it prefers to live without it in an oxygen-depleted environment. So oxygen isn't going to hurt it, but it prefers to live without oxygen. You might just heard this called pneumococcus pneumonia. So it depends on the kind of infection and bacteria. It can be diplococci, or it can be single, or it can be in chains. And that is why it might just be called pneumococcus. This causes the most severe cases of pneumonia. It causes about 80% of pneumonias. So Streptococcus pneumonia is an alpha hemolytic. So it breaks down red blood cells because the bacteria itself, those exotoxins, produce hydrogen peroxide. And that hydrogen peroxide is going to cause breakdown of red blood cells. And that hydrogen peroxide within the blood is also going to do damage to the structures around it. So this causes the most severe pneumonias. So it's going to do direct damage to the lungs and the tissue in the lungs. Now it'll start as a lobar pneumonia. So a lobar pneumonia is a pneumonia in one specific lobe of the lungs. And patients will present with a fever, chills, cough, difficulty breathing, chest pain. So a standard kind of cold, severe cold. But if that infection spreads from the lungs to the brain and the spinal cord, it can cause meningitis. Now, if it's thought that the patient has meningitis because they have a stiff neck, headaches, confusion, fever, then the physician will order a sample of cerebral spinal fluid, so a spinal tap. And that spinal fluid will be sent to the lab, and that's when they'll find the pneumococcal clusters or chains or diplo configuration and diagnose it as meningitis.
How do you treat that?
Antibiotics, and then also treating the symptoms. This severity is going to be more dangerous and more likely to happen in patients who are either very, very young, who haven't developed a good immune system yet, or very, very old, who their body is just kind of wearing out and their immune system isn't what it once was, or immunocompromised. So when I say immunocompromised, what do you guys think? What do you think of?
The immune system.
Their immune
Being weak.
system.
Autoimmune disorders.
Autoimmune disorders. Lucas, what were you going to say?
The immune system is weakened.
Yep, the immune system is weakened. So you can have either, it could be caused by like autoimmune diseases. Patients with cystic fibrosis, their immune system isn't compromised, but their immune system has to work harder. Or COPD patients who are chronically fighting something, their heart's already working hard to compensate for their disease, so they're more likely to get sick. But also for patients who have cancer or are on cancer-like drugs who weaken their immune system. Good job, guys. So bacteria and diphtheriae. So this is also known as diphtheria. It's gram positive. It's a bacilli, and it causes diphtheria. So you guys need to start thinking about getting your immunizations, right, for clinicals. So that Tdap or DTPA shot, the D in that immunization stands for diphtheria. And it's also tetanus, which is the T, and pertussis, which we are going to go over all of those. So you get 3 shots for the price of 1. So this is a rod. So you can see in this guy how the cell walls are at the ends of the rod, and that's why they stain so purple. And the cell walls in the middle of the rod are not as thick, so the stain didn't hold on as much, but they're kind of rounded on the ends. So diphtheria is going to be an upper respiratory infection. And it can be prevented by that Tdap vaccine. Before the Tdap vaccine was developed, diphtheria was the leading cause of childhood death in the United States. It's fatal in 10% of people. Its signs and symptoms are weakness, a sore throat, and when you look into the throat, you'll see gray and white patches, a mild fever, and then swollen glands and neck. And this can be, the infection can be caused either by contact, so coming into contact with it on a hard surface and then touching your nose or your mouth or your eyes, or it can be aerosolized. So if somebody is infected with diphtheria and they cough or they sneeze or they're standing really close to you and they're talking, they can pass it to you. So you can see the gray and white here. So upper respiratory would be anything above the glottis. So I know you haven't had pulmonary AMP yet. So anything in the throat and up. So if it causes swelling and irritation, an infection in the throat, what are we worried about? What can happen with that swelling?
The airway closing.
Yep, your airway closes. So that's why it can be fatal in 10% of people. And bacterial infections, there is no rhyme or reason to how fast they can become severe. So it might just be the perfect conditions that that bacteria just grows and grows. And all of a sudden you went from being okay and feeling fine to very, very sick. Okay, so Bacillus anthrax, which is also known as anthrax, is gram-positive. It's a bacilli. So it's typically found in hoofed animals, so cows, sheep, goats, farm animals, but they can transmit it to humans. So this is going to be something that's more commonly seen in areas that are largely populated by these animals, so lots of farms or ranches. There's several types, so cutaneous, gastrointestinal, so in the GI tract, respiratory, so they produce spores and then they can be breathed in, and those spores can settle in your lungs and create the infection. It can be spread through injection, and that's how it's going to be spread through the body the fastest, is if it's an injection. Because that circulation of blood is going to spread it throughout the whole body. Whereas with cutaneous or the GI tract or respiratory, it's localized into one area. These patients will be on Cipro, which is ciprofloxacin, for a minimum of 90 days. So it takes these spores 1 to 6 days to germinate. So the patient's not even going to see signs and symptoms for 1 to 6 days. But if it's left untreated, mortality is 100%. And early on, it resembles a common cold. So somebody may think, okay, well, I just have a virus, I'm going to stay home. And then all of a sudden they get very, very sick. And there's a short time window that they can get treatment before it results in death. So death can occur in 2 to 5 days, but germination takes 1 to 6 days. So that tells you that you go from feeling okay and maybe a little fatigued and sick to very sick, severe, that may result in death very fast. And that's because it causes shock, septic shock. So Clostridium botulinum, I'm not very good at saying that one, it causes botulism. And it's a poisoning, and it's typically a food poisoning. It's an anaerobic bacilli. So it only thrives with depleted oxygen sources. So when you think of botulism, think of like a dented canned food. So when they're, the process of canning, it's being vacuum sealed. Once it's dented, it's no longer vacuum sealed, and then that bacteria can start growing. There's not a lot of oxygen in there, which is how it thrives. So it's more common to be ingested through dented cans or homemade canned food that wasn't properly canned, salsa that's left unrefrigerated for too long, and then honey. So that's for those of you who have kiddos, that's why they recommend not giving honey to kids who are less than 1 year old, because they're less likely to be able to fight this type of bacteria off because their immune system hasn't properly developed yet. So this bacteria will cause flaccid paralysis because those exotoxins act as neurotoxins. So neurotoxins are going to bind to the nerve endings, and then it causes flaccid paralysis, which is an overly relaxed paralysis. So the eyelids will be more droopy. They won't be able to move their extremities. They'll have a harder time talking. And we'll see a picture here in a couple of slides. There is an antitoxin that can be used to reverse these effects and help that bacteria from binding to those nerve endings. Botulism is also used as Botox. That's what gets those muscles to relax in your forehead if you get Botox injections in your forehead and relax those wrinkles. So you're actually being injected with botulism. We can see an overdose if there's too much botulism injected. So here's an example of flaccid paralysis. So this patient, it looks like he's sleeping. He's kind of out of it, but he's awake. So down here, you can't see it, but he has a tracheostomy because this botulism infection has gotten so bad that all the muscles, including the skeletal muscles, have relaxed. So what respiratory muscle is the skeletal muscle that helps us breathe? Would be the diaphragm. So if the diaphragm is relaxed and it's not able to contract, we have to take over breathing for this patient or just help them increase their tidal volume, increase the breath they take in. And then we have the opposite. We have Clostridium tetani or tetanus. So this is part of Tdap. So tetanus, diphtheria, and pertussis. So this is an anaerobic bacilli as well. So it thrives better without oxygen. It also is spore forming. It's rare in the US because we have that vaccine. It's going to be more opportunistic. So it'll cause an infection in broken skin or injuries contaminated with an object. So if you get stabbed with something, with a knife, you step on a piece of metal outside and it goes through your foot, they're going to ask when your last tetanus shot was, because tetanus may be on that piece of metal that could cause a tetanus infection. So if that infection site, if you don't have the tetanus immunization and you don't get treatment for it and you stay home and it was a small minor cut and you still get an infection, neurotoxins will be released, but it will cause rigid paralysis. So know that botulism causes flaccid paralysis and tetanus causes rigid paralysis. So that's when the muscles, instead of being super relaxed, they're very tense and they're all contracting. It can cause lockjaw and eventually lead to respiratory arrest. So if we're not breathing and we're not getting our tissues the oxygen that it needs, respiratory arrest will lead to cardiac arrest and lead to death. There is an antitoxin that will also neutralize these toxins. And then we'll give antibiotics as well. So here would be some examples of rigid paralysis. So this is more common in third world countries who don't have access to these vaccines. So paralysis like this may be so intense that bones can break because those muscles are just contracting so hard and so much that the bones snap. Okay, do we want to take a quick break before we go to gram-positive?
Sure.
Okay, so
That'd be
let's,
good.
that one's pretty small. So let's come back at 10:05. All right. Okay, let's start with gram-negative. So what color does gram-negative stain?
Red.
Red, good. And I like to think negative or nasty because they're harder to treat with antibiotics and they are going to cause sepsis and worse infections easier. So remember, they stain red. They have a more complex cell wall. So on the inside of the cell, we have the inner cytoplasmic membrane. Maybe I can draw it and give you visual representation. So we'll say that this is the plasma here. And then they have the layer of the peptoglycan, which is the same as the gram-positive. And that's where the gram-positive cell membrane stops. That's their cell wall. But then gram-negative continue, and they have another layer of the cytoplasmic membrane. But then on the very outside of the cell, they have lipopolysaccharides, which is another cell wall that goes beyond that. So it's antibiotics and treatment on white blood cells are having to go through 4 layers to get to the inside of that bacteria cell to kill it. So it has that more complex cell wall. And when these lipopolysaccharides are broken, they release endotoxins. And that is what's going to cause sepsis quickly. So these toxins are going to cause cellular debris, cellular breakdown, inflammation, and these toxins are circulated throughout the entire body in the bloodstream, which causes sepsis, which causes septic shock. And if that shock is not reversed, then that leads to death. So remember, we're looking for fevers, or if it's an infected wound, the area will be warm to the touch. Swelling, pus is always a sign of infection. Someone who comes in with a pneumonia, maybe they have a pneumonia, and then all of a sudden they're more short of breath, their fever spikes while they're in the hospital and they're requiring mechanical ventilation. We're worried about sepsis. So treating infections as soon as we can with antibiotics is going to result in the best patient outcome. So we're going to go over each of these individually. So gram-negative bacteria, we have Pseudomonas, Klebsiella, Haemophilus, Bordetella pertussis, Legionnaire, gonorrhea, Serratia, and E. coli. So So gram-negative bacteria is less susceptible to antibiotics, and they have more powerful toxins. So let's start with Pseudomonas aeruginosa. It's an aerobic bacteria, so it loves to grow in oxygen-rich areas. So our lungs are oxygen-rich, right? So Pseudomonas is a common respiratory infection. We can find it as RTs in mist tubing. So once we get to therapeutics 2 and we start talking about equipment we use as RTs, so mist tubing, whether we're giving oxygen or humidity to our trach patients through this, in ventilator circuits. It can also be found in indwelling catheters. So you'll hear that they have a urinary tract infection that grew Pseudomonas because they had a Foley catheter. So they had a catheter for them while they were on the ventilator, and then they ended up growing Pseudomonas in their urine. Healthcare practitioners can carry it from one patient to another and not know it. So that's why hand hygiene is super, super important, that we are washing our hands regularly, that we foam in and out of our patients' rooms, that we properly clean our equipment. So Pseudomonas likes oxygen. We're going to find this on our bronchoscopies. We want to make sure we clean our PFT machines properly. Who knows what nosocomial means? So you'll hear the terms nosocomial and community acquired. So a nosocomial infection means we caused it. So that means that they got that infection once they were in the hospital. So they came in, they didn't have Pseudomonas, maybe they went on the ventilator, and then they developed Pseudomonas afterwards. It would be a nosocomial or hospital-acquired infection. If they came into the hospital with a pneumonia and it came back as Pseudomonas, it would be considered community acquired. So Pseudomonas is a big nosocomial infection that we worry about, but it can also be acquired in the community. So it's becoming more and more antibiotic resistant, which is very scary. Pseudomonas is a common infection that we'll see with our CF patients. So there are 2 CF centers in Colorado. You have the adult center at National Jewish and St. Joe's, and then Children's Hospital outpatient and inpatient has CF centers. So Pseudomonas is something, if you were working with that patient population, that you'll see commonly. And they are given inhaled antibiotics or IV. But Pseudomonas is becoming more resistant, so we're having to develop more antibiotics. And the ones that are out there right now are already pretty strong and hard on the body. You definitely have to watch their kidney levels and their kidney function, because that's where the body gets rid of that medication. So cystic fibrosis patients, cancer patients are more likely to get Pseudomonas, and then burn patients. They have all those open wounds, and those wounds might develop an infection. So Pseudomonas, so it smells terrible. Once you get out there and you actually are working with patients who have Pseudomonas, you're gonna be like, oh, that's what my instructors were talking about. The MBRC, so anytime you see anything that says MBRC, make sure you know it, because not only for our exams and our knowledge, but for your boards as well. So the MBRC calls it fetid. It has a, which smells like fermented fruit. It's this sour, sweet type smell. And once you smell it, you'll never forget it.
Is it kind of like cellulitis?
Kind of, yeah. It's and it's going to depend on where their infection is. So like sputum will smell different than if they have a UTI, but it's this same kind of weird smell. Sputum is green or blue-green. So always know if there's a special color, know your colors. And so it's like a nasty blue-greeny color. It's not a good infection. And then some patients can be so sick with it that you can smell it even before you go into the room. So Klebsiella pneumoniae is a gram-negative. It's a bacillus. It's a facultative anaerobe, so it can live with or without oxygen, but it prefers to live with oxygen depletion. It's opportunistic. So Klebsiella is a bacteria that normally grows in our gut and our bowels. But if it leaves our gut, then it's going to cause an infection in another area of the body. So if we have a patient who has a surgery and they have a perforated bowel, so that means there's a tear in their bowel, the Klebsiella will escape from there and go to other areas of the body, which can cause infection or sepsis. You can get this through community acquired or nosocomial if it's a pneumonia. It's also known as Friedlander's pneumonia, and it produces this red currant jelly-like mucus. So it's this very thick, tenacious mucus that's going to be a red-pink color. It's pretty gross. And with this thick, nasty mucus, our patients are at risk for mucus plugging. So the alveoli have mucus that's retained, so they're not going to be able to exchange gas properly. And healthy people usually don't get it. So this is usually, when we talk about it as a pneumonia, it's usually going to affect those, again, who are very old, very young, or immunocompromised. So this is the most common gram-negative bacteria that physicians see because it presents itself in so many different areas. So it can be a UTI and be in the urine. It can be in the blood. It can be in a wound, or it can be respiratory. Haemophilus influenza is a coccobacillus. It's anaerobic, so it prefers to grow without oxygen. There are 6 different strains, but the most dangerous one and the most common one that we see would be strain B, because it causes epiglottitis, which is that picture up here. So this would be a normal glottis. So you have, these are the vocal cords here. This is the epiglottis, and then it goes down to the trachea into the lungs. So this is normal, and with H flu, it causes swelling and inflammation. So you have to intubate because it will swell so much that it'll completely shut off their airway. So it's not actually a flu. When this bacteria was first discovered, they thought it was a virus and they thought it was a form of a flu. So they called it Haemophilus influenza. It's not a virus, it's a gram-negative bacteria. The sputum that is produced with this is very, very green. So it's more like the green on the slides, whereas Pseudomonas is going to be more of a blue-green. It is grown on chocolate agar. So when we talked about microbiology media and Petri dishes and agars, so a chocolate agar provides the nutrients that Haemophilus bacteria need to grow. Then we have Bordetella pertussis. So this is the last pathogen we're going to talk about that's part of the Tdap. It's gram-negative. It's aerobic, so it prefers oxygen. And this is why it causes what we call whooping cough. And whooping cough sounds like a barky seal-like cough. Let's see if I can get this to play. It's more common in kids. Let's see.
They're just kind of heavy. Uh-oh.
Can you guys hear it?
There we go. Okay. It's okay. Okay, take a breath there, honey. Come on. Almost there. There we go. Oh my. It's okay. It's okay. Yeah. It's okay. There. Yeah. It's okay. Yeah. Oh, yeah. It's okay, sweetie. Oh,
Poor girl. So it's got more of that barky cough.
Was that a productive cough or was that more of like a dry?
Good question. So you could hear, let's get back to it. So you could hear her cough something up, and did you see her swallow something? So it's more, it can be either. So the majority of the whole time she was coughing was dry, but there was a small period when she did get something up, and then she swallowed it. Poor thing. So it's more common in kiddos, especially 2 years and younger. And it's often transferred to the kid from either older siblings or their parents or caregivers who don't know that they're carriers, or they don't know they've come into contact with it, just because the little ones can't fight that bacteria off and they're not old enough to get the vaccine yet. So that's why it's so important that entire families are vaccinated, have vaccinations, so that they're not accidentally passing something to younger children. Pertussis is a very, very contagious. It's transferred via respiratory droplets. So coughing, sneezing, talking. That's why newborns, you might hear moms say, don't kiss my kiddo, because coming into close contact during respiratory season can accidentally pass something to that baby. When you have pediatrics with Justin, he'll teach you about specific treatments, signs and symptoms. So for right now, for pertussis, know that it's a dry, barky type cough. And this bacteria actually attaches to the cilia, and then the toxins that are released does damage to the cilia, which decreases their movement, so they're not able to move their mucus properly. And it causes the airway to swell, which is why when you heard her try to inhale, it had that high-pitched stridor sound, because her airways are all swollen. Legionella is also called Legionnaire's disease, because the first big outbreak was found at an American Legion conference in 1976. through this hotel because Legionella loves to live in the water, and specifically warm to hot water. So at this conference, they found large colonies of Legionella in air conditioning units. So this is common in hotels or large areas of water, hot springs, shower heads, sinks and faucets is where it loves to live, hot tubs that aren't cleaned properly or maintained with chemicals properly, decorative fountains of waters or water features, hot water tanks and heaters, big plumbing systems, and then with those water droplets, the Legionella is inhaled and then causes infection. So this is important when we are treating patients. We're always going to get their history. And so, you know, asking questions like, have you been on vacation recently? Where did you go? What did you do? So they might say, oh, we went to California and we went to this water park and we stayed in this hotel. So that can lead you to the idea of what pathogen might be affecting them. Gonorrhea, is a gonococci. It's gram-negative. It's typically a sexually transmitted disease, but because it is transferred through mucous membranes, it can also infect the nose, the throat, the mouth, and the eyes. So once we have an infection in the throat and the upper airway, then it becomes a respiratory disease as well. And we worry about our airway being compromised. Serratia is an opportunistic bacilli. This is one that you might actually find in your shower. So in your shower, it likes to live in the grout or in the corners of your shower. And if you see like a pinkish orangish color that you know you clean every week in a bathroom, that's actually a bacteria, Serratia. It is found in the soil as well. So if someone does a lot of gardening and they're tilling up their garden, these particles and bacteria, spores might get in the air and they might be inhaled. But this is more likely to happen as nosocomial outbreaks. Okay, so E. coli is our last one. It's gram-negative. It's a bacilli. We normally have E. coli in our GI tract as part of our normal flora. But like with Klebsiella, if we have a perforated bowel and it has the opportunity to travel and infect another part of the body, it will. I can never say this right. Shingai toxin is a specific strain of E. coli, and this is a strain that's going to make people sick through food poisoning. So we need to make sure we're washing our fruits and our vegetables, that we're properly washing our hands before we eat, cooking meat all the way through, or if we order food from a restaurant and someone hasn't washed their hands, it can be from that, because E. coli is found in the environment and food, and then feces as well. So this E. coli has a wide variety of symptoms. So you can have NVD, which is nausea, vomiting, diarrhea. It can cause respiratory illness like pneumonia, or it could cause a UTI. If E. coli infection is nosocomial, if they get it in the hospital, they are more likely to be antibiotic resistant rather than an E. coli infection that happens outside of the hospital and is community acquired. Here's some resources for you. The CDC has excellent resources. I always highly recommend going to the Center for Disease Control or to the World Health Organization, or even local health organizations are great resources for you. Do you guys have any questions, thoughts, concerns?
The MRE that's due today, is that over today and Friday's content?
It's Fridays.
Just Fridays? Okay.
Fridays. And it's pretty short. It's like 10 questions, 10 or 12. So review your Quizlet before you take your MRE again, and you'll be fine. Okay, well, I'll let everyone go and get to work, and we will see you guys on Friday.
Thank you.
You're welcome. Bye, guys.
Thank
Bye.